My name is Xiao from Xiao Hospital at Central South University in China. I'm very pleased to be here for this IPC Tech 10 presentation. Today we'll be discussing a crucial topic, women, hormones, and psoriasis, and we will explore the relationship across the female life course from pregnancy to menopause. So um, why this talk and why now? This is a life course evidence-based agenda. We have three primary motivators. First of all, we need to address a gap. In the clinic, we are seeing higher care needs for women, particularly during the pre and post-menopause phases. And this is also where late onset psoriasis and PsA are becoming increasingly relevant. Second, our female patients facing critical decisions. We must be able to guide them in navigating key life stages, such as pregnancy, contraception, and the use of HRT, all in the context of their diseases. And third, we are answering the Lancet call. In 2024, the Menopause series in Lancet urges us to integrate sex-based biology into our practice and research, moving away from the over-medicalization and towards gender empowerment and equality for our patient. When we look at psoriasis over the female life course, we see distinct patterns emerge. During the menstrual cycle, many women report symptom exacerbation in the premenstrual phase, which we link to the estrogen withdrawal. We also have data linked to irregular cycle themselves to a higher risk of psoriasis. Next, pregnancy and postpartum. This is very common to see improvement in the second and third trimester, but critically, we must warn patients of the rebound window that occurred 8 to 6 weeks postpartum, which carries a higher risk of flare. Finally, menopause. As this graph shows, we observed a second peak in the incidence of psoriasis for women right around 55 to 64 years old. And this is often tied to the late onset psoriasis, PsA, and related comorbidities. So we focused on the key hormone, estrogen. This role is bispecific, means it is complicated. On the one hand, it has very protective side. At the physiological level, estradiol E2 is known to suppress key inflammatory cytokines like IL-1 beta and IL-17A, and it also supported the skin barrier repair. And this is supported by the basic science study, as shown in the histology image here from the Adachi Jackie paper, maybe in 2022. And on the left, compared to the control shame surgery, ovary ectomy or removing the ovaries, OVX, significantly worsen the inflammation and thicken the epidermis. But on the right, when those OVX mice are giving estradiol, the inflammation is suppressed and the skin normalized compared to placebo. So on the other hand, there is also a problematic side. The final outcome isn't simple. It depends on the balance of the estrogen receptor, alpha and beta, the dose and the local synthesis in the skin. So as a clinical anchor, a recent 2025 JAD population study paper have also linked circulation E2 level with the skin, with the disease activities. I remember this is paper from Professor Yin Zhiqiang. So although this is an observational study, but it's really worth into discovery in the future. So to get stronger prospective evidence, our team conducted a study in using the UK Biobank. We found that the endogenesis estrogen is productive from incident psoriasis and PsA. Specifically, a later age at natural menopause and a longer productive lifespan are both associated with a lower risk of developing late onset psoriasis or PsA. And this is the core data from our 2024 JID paper. This forest plot showed the adjusted model. If you look at psoriasis compared to the women with menopause before age 45, those who underwent menopause at age 55 or later have a 34% risk reduction. The effect is even stronger for PSA, 46% risk reduction, and we see a similar productive trends for longer reproductive lifespan. And we are also doing the animal study right now, and the conclusion is consistent. The implication is clear, is that the duration of the endogenesis estrogen exposure matters. And for our practice, this means that we should be integrating life stage stratification into our long-term follow-ups and our quality metrics. And then, but estrogen isn't the only hormone involved. Let's look at prolactin. A key insight here is the role of local prolactin production within the lesion themselves. For psoriasis, this local production has been shown to correlate with PASI severity. For PSA, these findings are also very compelling. Prolactin is present in the synovial fluid and tissue, and its receptor, PRLR, is highly expressed on the CD68 positive macrophage in the joint. The proposed mechanism is that prolactin synthesizes with other inflammatory signals such as TNF or CD40L, which in turn drive up IL-6 and IL-8 and activates macrophage. As a clinical note, it is interesting that some systemic therapies such as methotrexate have been observed to reduce prolactin level in certain cohorts. So finally, what about androgen and progesterone? The data here show they both have very productive tendencies. For androgens, lower level have been linked to the great disease severity in some study. For progesterone, it is generally known in immunology to promote immune tolerance and dampen T cell activation, including the Th17 axis. The main clinical view here is that we must consider the entire hormone picture when we are interpreting patients' disease severity and tailoring their therapy. So how about the exogenesis hormones such as the HRT and contraception? This all lead to this practical clinical question. The honest answer is that the relationship between these hormones and psoriasis risk remain complex and varied. Different studies show different results. This is precisely why individualized shared disease making is essential and must replace our old uniform protocols. For any patient on these therapies, ongoing monitoring of not just their skin and joint, but also their cardio and metabolic health is very, very imperative, especially for the women that after the menopause. So what can we do differently? I want to leave you with 3 practical actions tomorrow, which align with the IPC practice framing and the Lancet empowerment model. First, schedule a very specific postpartum review at 8 to 12 weeks. This is to activate access to that rebound flare, adjust therapy if needed, and ensure any new plan is lactation compatible. Second, create a premenopause bundle. This means activate the access for menopause symptoms, screening for PSA risk, which can be done simply through question tours and monitoring their cardiometabolic health. Third, develop a very clear contraception and HRT plan. This involved a sharing decision-making process where we outline expected facts, the red flags to watch for, and set a clear follow-up schedule. Of course, we need to do more study and research on the evidence of the HRT on their does it have like production effects on the severity of psoriasis, and we need to do more in this area. So looking forward, our research must continue to evolve. We must pre-specify life stage and hormone status subgroups in our future clinical trials. And we need to focus on meaningful outcomes that matters to patients, such as function, work participation, and their personal preferences. And we must increase women's leadership in both dermatologist and the patient perspective to protect more about the rights for the women patient. This brings me to my final take-home message, which is threefold. Think life course focused on empowerment and strive for equity. So thank you again. I'm Xiao from Xiao Hospital, and thank you so much for your time. And in the end, here are the reference using in this presentation, and I have no conflict of interest to declare.